All right, we're recording. So, welcome to week 12. So this week we've really got two lectures because the tutorial time will be a lecture as well. Okay, so in this lecture we'll look at the myeloproliferative neoplasms. I think in your unit schedule it may have the term disorders, but again, when I was writing this lecture, looking in the textbooks that I was using, the most up-to-date textbooks, they actually use the term neoplasm rather than disorder, but they mean the same thing. And then tomorrow in the tute time we'll be looking at the myelodysplastic syndromes. Okay, so instead of a spot quiz, what I'm going to do today is I'm going to present you a case study at the beginning of the lecture with some questions for you to answer, and then we will hopefully, I'm hoping that we will have enough time at the end of the lecture to come back to the case study and for you to give me your answers. Okay, so through the lecture I want you to pick up any hints that you can about what this case is, and then we'll discuss it. Hopefully we'll have time to discuss at the end of the lecture. So if this was in the prac time, you would probably have you'd have an F for female, 66 years old, and you might have either splenomegaly or you might have abdominal discomfort. You probably wouldn't have both, because we know that on those blood film reports the clinical information is really very brief, isn't it? But it should still give you enough of an idea about what's going on. And we can see that, what does the 2 on 12 stand for? 2 months, yep, okay. So there's a full blood examination requested. So the full blood examination includes the full blood count, the FBC, and the peripheral blood film. So these were the pertinent results from the full blood count. So we've got a red cell count that is within normal limits but right up near the top. Hemoglobin, that's in the middle there. The white cell count is very high, isn't it? The MCV is within normal limits, and the platelet count is increased as well. This is what the blood film looks like. So I'll give you a minute or so just to really have a good look at that blood film, because you're going to have to keep this in your head for the whole of the lecture, okay? How are you feeling when you look at that blood film? Are you thinking, holy crap, Batman, what's that? Or are you feeling a little bit more comfortable about looking at abnormal blood films? Yeah? You still a bit unsure, or are you feeling comfortable? Any comfortables? Yes? Excellent, that's great. My work here is done. Okay, so that's the blood film. So try and keep that in your head. And so these are what I want you to answer by the end of the lecture. So the possible conditions that are suggested by these results, keeping in mind that we are in a lecture about myeloproliferative neoplasms. Further laboratory tests that are needed to help you to differentiate which disorder it is and why you are asking for those tests, and then to give me the expected results of those tests, depending on what disorder it could be, okay? So very, the same sort of thing that you do in the pracs, the same sort of thing that we've been doing in our testing. So we've got 5 learning objectives again today, and so the first of those is defining the term and also looking at the WHO classification, looking at pathophysiology and general characteristics, and then going through each of the disorders and describing their clinical presentation, their laboratory features, including screening tests and further tests, and with some of them looking at the prognosis or some of the current types of therapies that are being used. Okay, so we'll go through each of those. So this is actually a really useful diagram that in retrospect would have been really good to have at the beginning of this this learning module, and I'm even thinking of putting it into Hem 1 at the next semester, because I think it just gives a really good overview of how all of the white cell dysplasias in particular sort of slot together and fit together. So at one end we've got our benign disorders. So this just means that we have abnormal numbers of cells. So something has happened within the body that has upset the homeostatic mechanisms of the body and has resulted in a response of either a reactive leukocytosis, so we've got an increase in our leukocyte count, or a leukemoid reaction. Now just remind the person next to you what that term leukemoid means. We have mentioned it before, but it probably hasn't been for a while. What does that term leukemoid mean? If you can't remember what it means, look at the word and work out what it means. Anyone like to have a stab at what it means? It has to do with the white cells, yep. So the leuc part tells us that it's to do with the white cells. The M part. Yep, so they're great. It's not just that they're greater than normal, because that's what that term reactive leukocytosis means. That tells us that we've got more white cells. What does that oid mean?
It means it could be like leukemia. It's like pre-leukemia. It presents like leukemia, but it's not.
Exactly. It presents like leukemia, but it's not. So leukemoid reactions are things where you'll get an increase in the white cell count, and you'll get quite a marked neutrophil left shift. So when I say marked neutrophil left shift, what do I mean? What sort of thing will we see on the peripheral blood film? Yep, you'll see band forms, but we will also, if it's marked, we will see earlier than band forms as well. So it could go to metamyelocytes, and you may even see an occasional blast cell. You may even see, but it's usually sort of that myelocytes, metamyelocytes. So that's why we say it's leukemoid. Because you'll see later in a minute that is very similar to what we see in chronic myeloid leukemia. So that's why we say it's a leukemoid reaction. And that's like a knee-jerk reaction of the bone marrow to quite severe infection, is usually when we see a leukemoid reaction. And as you'll see today, we can see it in other situations as well. So they are benign, so they don't hang around for very long. So it's like all of our homeostatic mechanisms within the body, they stay around for as long as they're needed, and then they go back to their normal values because their job is done, particularly when we're talking about white cells, because we're talking about our immune system. We're talking about our body's defences. So our body's defences, as we know, are mobilised when we need them, and then they go back to their steady state of readiness when we don't. So that is not a persistent condition. And then we move a little bit further along our scale here, and we find this is where we see the myeloproliferative neoplasms, which we're going to talk about today. And then a little bit further along the scale, so it's myeloproliferative. So we're talking about a quantitative change here. Proliferate, that means more, so we're looking at an increase in our white cell count. And then further along here we have our myelodysplastic syndrome. So this is where we have changes in quality of the cells. So these are qualitative changes on the whole. So then we can get right at what we call the malignant end of our scale, and these will certainly kill you if left untreated, and this is where we have our acute leukemias. And then, of course, just to make things difficult, in the middle here we've got a combination of disorders that have been at various times classified as either myeloproliferative or as myelodysplastic, but they sort of sit somewhere in the middle there. So, as I said, we've got this spectrum. So we can see that the myeloproliferative neoplasms certainly are nowhere near as aggressive as other forms of neoplastic disorder, but the thing with them is that they can transform, and they often do. And so they can transform into these more aggressive syndromes, okay? And I think if you remember back to the blood films last week, one of those was someone who had a known myeloproliferative neoplasm. I think it had MPD, or it could have even been, it might have even been MDS, it might have been a myelodysplastic syndrome, but they actually had transformed to an acute lymphocytic leukemia. Okay, do you remember that one? Yep. Okay, so when we have a look at the definition of what myeloproliferative neoplasms are, they are clonal hematopoietic disorders, just like the acute leukemia. So they are clonal stem cell disorders. They're caused by genetic mutations in the hematopoietic stem cells. So this is very early on where we get these mutations, and there are a number of those mutations which result in expansion, excessive production and accumulation. So that's where the proliferation bit comes from, of erythrocytes, granulocytes and or platelets. So of course they all come from the myeloid line. So these, the myeloproliferation is because of a hypersensitivity to the effect of proliferative cytokines, or they don't, they are, it says in the text that it's an independence of these cytokines, but it's almost like they're either hypersensitive to some cytokines and they're not reacting to other cytokines, okay? So they have this unchecked proliferation and clonal expansion. And again, it's an abnormal clone. So like the lymphoproliferative disorders that we talked about last week, it's a very slow progression. So they're chronic conditions, but they can have different phases. And these are given different names, but basically it's when all of a sudden this slow progression speeds up. Okay, so it can either be accelerated to a subacute or acute phase, or it might be called a blast crisis or a transformation, a blast transformation. So there's various terms that are used, which makes it a bit tricky, depending on the condition you're talking about. But it seems like you have this really slow, chronic condition that just burbles along for months or years, which can then go through transition stages of acceleration and then into a blast phase, into an acute phase. The other thing is that the reason that they are classified together, these disorders are classified together, is because they do have common pathogenic clinical and laboratory features, and at the same time they have differences as well. So this is a real case of compare and contrast to work out which disorder you're talking about. So the thing with the myeloproliferative neoplasms is that all of the cell lines can be affected because they are, the myeloid cells, and we'll see in a minute why we can also have this transformation to actually an acute lymphocytic leukemia. So while all the cell lines can be affected, it's usually just one cell line that predominates. So we may have increases in all the cell lines, but there'll be a particular increase in one cell line in particular. The WHO classification, now this is the 2016 revision of the classification, And again, the main difference is in the name. So in your books, it tends, I think the names are fairly similar. I think the main difference is around primary myelofibrosis. It's also called idiopathic chronic myelofibrosis as well. But I'll check that when we come to it later in the lecture. And polycythemia vera, I've always known that as polycythemia rubra vera, PRV. So again, there's just these differences in the nomenclature that you need to be aware of, and that they mean they mean the same thing. So on this table here, the ones that are in red are the ones that we're going to be talking about, and the ones that you need to know about. So again, the WHO classification relies not just on the FBC and the peripheral blood count and the bone marrow, so not just on the number and the morphology, but also on our additional tests. So our certainly molecular analysis and our genetic analysis and cytogenetics, they don't rely that much on immunophenotyping. And I think that's because they probably show the same markers as normal cells do, the same CD markers as normal cells do. So the further tests that we focus on with the myeloproliferative neoplasms are more the cytogenetics and the molecular analysis. Okay, so when we look at the general pathophysiology, you can see that the reason why we've got this mixture of conditions and the way that they can actually transform into other conditions is because of this here. So this is where the defect is happening, right back in our haemopoietic stem cell. And you can see from this haemopoietic stem cell, in normal situations, this haemopoietic stem cell can differentiate and proliferate into either the common myeloid progenitor or the common lymphoid progenitor. So way back here, we can have genetic mutations that we can then find in cells of this clone that are myeloid cells and lymphoid cells as well. Okay, so that abnormality is there, and that tells us that even though, well, I guess these days we can actually now identify and separate off these haemopoietic stem cells, but it tells us that it is a clonal mutation that's happened that affects really all of the cells in the clone that the haemopoietic stem cell is able to develop into. So you can see there that we have a number of different genetic mutations that can happen, and the defective clone has excessive proliferation, but the commitment to a cell line, the differentiation to that cell line, and also the maturation is not affected. So it's not like the acute leukemias where we have that maturation block. Okay, in these, the cells mature all the way through. It's just that we've got lots of them. And just like the other proliferative clones, they actually end up taking over the bone marrow and sort of squeezing out the normal haemopoietic tissue. So the most consistent chromosomal abnormality that we see with these neoplasms is the Philadelphia chromosome here, and also a mutation in the JAK2 gene. And these are the two that you need to keep in mind, and we'll be talking more about each of these when we look at the various diseases that they're involved in. So our general characteristics, and it shouldn't come as any surprise to you that these conditions are conditions of middle or older age. So just like other cells in our body that don't become as efficient and as effective as we age, it's the same with our haemopoietic tissue as well. So it ages and it I guess the older we get, the less effective our quality control measures are, and the more likely we get mutations happening. And I'm sure Steve has talked to those of you who are doing molecular biology about that. The fact that mutations are more common the older we get. And it is just like the lymphoproliferative disorders, it is a chronic condition with a gradual onset. And you can see here that it can be months to years. So it can be really a long time. And it is thought even that some older people, the older form of ALL that we talked about, so remember when we talked about acute lymphocytic leukemia, we said that there are two spikes in the ages. There's the spike for the young people and there's a spike for the older people. And it's actually thought that that spike for the older people might be the blast phase of a myeloproliferative neoplasm. It's just a thought that I read when I was preparing for this. So there are some common clinical features that are all to do around an abnormal cell clone, either having too many cells there or the cells not working properly. Although you can see here that it is possible in some of them that we do actually have anemia happening. And you can see here that when we do have anemia, we don't always have anemia, but when we do, it's due to either ineffective erythropoiesis, so our red cells are not dividing properly, and so we're going to end up with larger cells or weird-shaped cells because that division and maturation and proliferation isn't being followed properly. We get anemia in myelofibrosis because what happens in there is we have our tissue, our fibroblasts, our tissue fibroblasts. So remember those way back in AMP when we were learning about all of your different tissues and your connective tissue where you have the fibroblasts there. So they are actually part of the myeloid line too in the bone marrow. And so when we get myelofibrosis, again, we get this fibrotic tissue that's squeezing out all the other tissue. We can end up with anemia. And also splenic sequestration. So when there is issues with hemapoiesis, often we find our spleen and our liver are also involved because they are still hemopoietic organs, and so we can actually get anemia through splenic sequestration. But interestingly enough, it doesn't seem as if the spleen sequesters the platelets. It seems to be mainly the erythrocytes, but that could be because of the ineffective erythropoiesis, and so we've got abnormal blood cells that are being removed. So you can see here that we can have polycythemia, we can have, now who can remember what this term means? Leukoerythroblastosis. Commonly termed LEB. If you can't remember, have a look at the word, see if you can work it out. So it's something to do with the white cells and the red cells. And what do you think blastosis is? So blast forms are increased. So it is a condition where we get blast forms or early forms of our leukocytes and our erythrocytes. And so again, we can see this is often a case, again, showing you that I guess the normal bone marrow is having trouble keeping up with tissue hypoxia, and so they tend to just sort of throw everything out in an effort to catch up, and the leukocytes get caught up with that as well. We can have thrombocytopenia or thrombocytosis, and we can have quite bizarre platelet morphology. And certainly in myelofibrosis, we can get bone marrow fibrosis as well. So this is a lovely table that I found in Mackenzie, which is one of the other really good haematology books that I know is in the library. I don't know if any of you have actually had a chance to have a look in Mackenzie. But this really just sets out all of the differential features for you. The one I've blocked out is CNL, which stands for chronic neutrophilic leukemia because it's often talked about when we discussing the myeloproliferative neoplasms, but it's extremely rare. There's only been about 150 cases ever found of this particular condition. So I thought it's going to be hard enough you being able to get your head around the information that I am giving you without giving you information about a very rare condition. So that's why I've blocked it out there. So you can see here for the conditions that we're going to talk about: chronic myeloid leukemia, essential thrombocythemia, polycythemia rubra vera or polycythemia vera, and primary myelofibrosis. And this one is chronic eosinophilic leukemia, not otherwise specified. Okay, so that's what that means. So these are the ones that we're going to look at, and you can see there's peripheral blood features here for you to look at. Also, what's happening in the bone marrow, or bone marrow fibrosis, splenic size, and also the famous Philadelphia chromosome. So I think that's quite a lovely table.